Hi, everyone. Welcome and thank you for joining us. My name is Almira. I'm an R4 at UIC, and together with Grace, who will be talking to you in a minute, we will be moderating today's session. Today, it's going to be, it will be about head and neck, and I have the great pleasure of introducing Dr. Burce Ozgen as our faculty for today. She's an associate professor of radiology at UIC, a dedicated teacher, and a recognized name in the head and neck world, both nationally and internationally. She has more than 15 years of scientific contribution to the field. That aside, what I as resident find amazing about her is that in every single case, she finds something new to teach you. There's no such a thing as a boring case when we read out with her. So that's why I'm really confident that by the end of today's session, all of us will learn something new. Now, before we start, let's talk some logistics. This session is going to be case-based as usual, and I will be calling upon the resident volunteers to take the cases. But it's going to be 2 separate rounds. On each round, each resident will take only 1 case. Now I'm going to turn to Grace for more logistics.
Hey guys, I'm sure you guys all know me by now, but I'm Grace. I'm one of the 4th-year residents at University of Utah, and I'm going to be kind of doing more of the monitoring of the chat and make sure that we can get all your questions answered, and in a way that's less disruptive to the flow of the lecture. So, well, we're going to try something a little bit new this time. If you have a question that's super urgent and you're like, I'm going to die if I don't find this out right this second, then just don't put the Q in front of it, and it's fine. We'll go ahead and interrupt Dr. Ozgen and get your question answered. But if you're like, hey, you know what? I am okay. I'm not going to die. Put a Q in front of it, and then we'll answer it all at the end, kind of one rapid fire, and just be like, hey, these are all the questions, and we'll just kind of go one by one. So you guys decide, but if you can put your Qs in front of your questions, I think that will be really helpful for the flow of the session. All right. I'm not going to delay this any further, so Dr. Ozgen, go ahead and take this away.
Thank you so much, and thank you, Elmira, for that kind introduction. I love to teach, so hopefully, we'll all of us will have fun and great time. I'm just trying to share a portion of my screen. Let's see if that will work. How does it look on your screens?
Looks great. You can see everything.
Excellent. So I don't know how other people have done this, but the way I plan this is that I will present you a case, usually even give you an option of multiple choice questions, and then of course I'll give you the answer, but then I'll share a few more slides kind of going into more detail of that topic, give you some kind of take-home diagnostic points after each case. So the funny thing is that when I wanted to gather this talk, I went ahead and looked at the ABR to see what kind of topics would be more relevant to you for the sport. And that's what I saw for cecal base and treble bone. And of course, it's a huge list, but I'm not going to go over each and every one of them, but I'll try to kind of cover, I think, the most important ones. So let's go and let's start the cases. Okay, the first one is this one. I don't know, Elmira or Grace, if you want to appoint somebody to this one.
Sure. The first one will be Grace. She's R4 from University of Utah.
Okay, so this is something we see more and more frequently nowadays. And I'll first actually scroll through the case, but then I'll kind of show you the relevant image and the question. So let me just scroll through it. And okay, try to look. I'm trying to go slowly now. It's going to be a basic question, so don't worry if you haven't looked at every single detail.
Okay.
Okay, so the question is, what can be seen with this type of fracture? Sensorineural hearing loss, purulent fistula, normal aberrant, or all of the above? What do you think?
Well, so we have bilateral, kind of horizontally oriented temporal bone fractures. Kind of a little bit hard to see because they were so symmetric, so it's a little tricky.
Great.
But definitely shouldn't see lines there. I would say sensorineural hearing loss for sure, just because you are kind of going through going through a lot of the inner ear structures and also going through that middle ear cavity. So I would say sensory neural hearing loss. Perilymph fistula, I think that's reasonable as well, because you are going through the semicircular canal. So then usually if I can get two, then I go with E, all the above.
Perfect. Yes, the answer is all of the above. So we'll talk about it in a second, but then I would like you to classify just those fractures.
Sure. Yeah.
So what do you think we can call this fracture? And actually, there isn't a single answer. You have to give me two right options.
Okay, I would say this is a transverse fracture, and I think it's going. I'm trying to decide. I think it's going through the otic capsule, so it is otic capsule disrupting. So it would be A and C.
Excellent. Absolutely right. And yeah, so just to delineate what an otic capsule is, this is this bony kind of island here, which is one of the strongest bone in the body, is the otic capsule itself. So anything that kind of crosses through it, anything you see coursing through the inner ear structure is a fracture involving the otic capsule. So if we kind of go back to our classical classification, that's, as you pointed out, that is a typical transverse temporal bone fracture. It's perpendicular to the petrous bone. So that's the kind of orientation of the petrous bone, and that is completely perpendicular to it. So that's transverse temporal bone fracture. And it happens when you have an occipital blow, such as that. That's kind of the image I always try to remember, like from behind, you end up with this kind of fracture. Of course, you can get it after falls as well if you hit the back of your head. And as you pointed out, the fracture lines go through the inner ear structure and IAC, and that's why you end up with sensory neural hearing loss. But you can also have perilymphatic fistula because it kind of connects the CSF in the posterior fossa and also the fluid in the inner ear structures with the middle ear cavity. That's why you have the perilymph fistula. And then, of course, because of that connection, the air in the middle ear cavity can go into the inner ear and vice versa, and you can end up with pneumolabyrinth. Also with this fracture, as it's coursing through the IAC, or it kind of involves the facial, different segments of the facial nerve injury is much more common. The problem with that traditional classification is that it doesn't really work well in terms of predicting the outcome, complication, and so forth. So this is actually the current classification. You shouldn't have the option of traditional classification, but I'm sure they have some kind of older questions in their database, so you can always get the kind of traditional classification as well. But that's what you have to use in your daily practice from now on. You have to say whether it's involving the otic capsule or not. And as you can see, this one goes all the way to the middle ear and there's an ossicular dislocation. However, it does not involve the otic capsule. So it is otic capsule sparing fracture. However, this one again goes to the otic capsule. It's an otic capsule violating, disrupting fracture, again, accompanied with all the sensory neural hearing loss, pneumolabyrinth, and so forth, all those additional complications. All right, so that's it with this case, and we can move to the next one.
Okay, so next one will be Prashant. He's an R4 from Boston Medical Center.
Hello. So let me show you the images. Okay. I think it's pretty straightforward, but I'm not going to ask you what it is. I'm going to ask you, what do you think is the most common cause of this entity? So you have to kind of tell me what it is, and then what do you think is the most likely underlying cause?
So, initially you showed sort of axial CT followed by a couple of slices through the same level of MR. The notable features are that this is sort of like two masses that have on the flare, there was some surrounding hyperintensity suggestive edema, but otherwise some centrally restricted diffusion. And in the contrast MR sequence, peripheral enhancement. So I would say that this looks like a cerebral abscess. And what were the answer choices again?
Of course. And think about the location. So at this specific location, what do you think is the most common cause?
Yeah, I mean, it looks like it's kind of seated centrally at gray-white gray-white interface. So I would say that septic embolus is probably a common, the most common etiology of these ones presented.
That's so true, but especially if you have something in the temporal lobe, think of lobes, like frontal versus temporal, especially if you have a temporal lobe abscess. And as we are doing a kind of head and neck session, what would you probably go for?
Possibly then like coalescent otitis.
Exactly.
Yeah, you know, if you'd showed me sort of like the posterior fossa and some thrombus as well in like the sinus, I probably would have went for that too. But,
Exactly. But that's the thing, that, you know, sometimes as a radiologist, this is what you're going to see in an ED setting, right? You might have a patient coming in with an intracranial abscess, and as soon as you see a temporal lobe abscess, you have to really go and scroll through your images and look at the adjacent temporal bone. And that's actually the CT images belong to the same case. And you can see that that is definitely coming from the ear. And you can see there is complete opacification of the medial ear. And furthermore, the tegment has a big dehiscence or resorption, as you can see. And that's why this infection went upward to involve the temporal lobe. So whenever you have hemorrhage in the kind of posterior inferior temporal lobe, think of transverse dural sinus thrombosis. And when you have an abscess in this location, think of middle ear infections. Let me just show you a few more important features about acute coalescent mastoiditis. So in the regular simple otomastoiditis, they don't ask for imaging and we don't really see those cases. They only request imaging when they suspect complication. And this is the setting of a complication of acute otomastoiditis called coalescent otomastoiditis. And as the name implies, you'll have coalescence of the mastoid substation, as in here. Sometimes it may be tricky to kind of delineate whether or not there is coalescence because the mastoid antrum itself is kind of a big empty cavity. But if you look laterally, you should actually normally see all those septation, which you don't over here. So this is an example of a coalescent mastoiditis. And of course, now is the second question. What is the most common complication of this coalescent otomastoiditis? What do you think? And that's a very difficult question, you know? That's fine because they are sometimes close in incidence.
The most common complication of this type of otomastoiditis, I'll have to guess.
Yeah, go ahead. Just
maybe like subperiosteal abscess.
Exactly, that's the case. Actually, if you have you don't even need to be a head and neck radiologist. If you have read enough ED cases, especially in a pediatric hospital, you'll see that this is so much more common than everything else. Of course, these are the things that we are more afraid of, but that's overwhelmingly the most frequent thing that will happen in this instance. And what happens is that the coalescent mastoiditis can go laterally into the lateral soft tissues, and then you end up with an abscess in the perioauricular and typically retroauricular region, dream-enhancing on CT or an MR, doesn't matter. And of course, the other way, it can also progress the other way around. You can have coalescent mastoiditis again, kind of progressing medially. And here, for example, in this case, which was a difficult case, to be honest, you can see this little air bubble here, just adjacent to the mastoid. And on the post-contrast images, you can see this little rim enhancement, and that was an epidural abscess, and again, in a coalescent mastoiditis. And again, the diagnosis of coalescent otomastoiditis, as you can see, it's tricky. You know, is there a little bit of coalescence here? You don't know, but usually when they ask imaging, there must be a reason that they suspect coalescent mastoiditis. So your job is to look for all those potential complications in the setting. Yeah, so that's, for example, a better and an easier case to delineate the epidural abscess, and things can go further, and you can end up with a dural sinus thrombosis, as you can see here. Let's go to the next case.
All right, that's going to be me.
All right. Okay, so this is a little bit difficult case, just to warn you. Don't be scared. Little girl, but the history is very typical. She's coming in with severe progressive hearing loss and has a recent history of meningitis. And I think you can even guess the diagnosis from the history. Let's look at the images.
All right, so we have two cyst images above and one post-contrast FATSAC T1, I believe, below. And it looks
probably
like...
not FATSAT, but post-contrast, yeah.
All right, oh yeah. So, her symptoms were bilateral.
Hearing loss, bilateral,
bilateral
progressive hearing loss.
Yeah. So what I can see here that there's some enhancement in the semicircular canal bilaterally. So I'm gonna go with probably labyrinthitis, or you're gonna show me the question, right?
Yes.
All right.
Thanks. for stopping right there. So what do you think is the diagnosis? Has there been a hemorrhage in the inner ear, or ossification, otosclerosis, or large endolymphatic duct of sac? So what do you think? Oh,
yeah,
sorry.
so I didn't have the pre-T one, so I'm not gonna pick hemorrhage. So meningitis, so that's why I'm gonna go with B, labyrinthine ossificans.
Okay. Again, the history here is really the thing that makes the whole difference. A small kid, meningitis, and then having progressive hearing loss, you have to think about labyrinthitis ossificans. So, and now is the more difficult question. What do you think is the recommended treatment?
Is that a steroid and then follow-up?
That's, yeah, that would be kind of easy, but unfortunately, this is one of the few imaging emergency and surgical emergencies in otorhinolaryngology, because that if you have found that there is enhancement of the inner ear structures after a meningitis, it means that there is an ongoing inflammation in the inner ear structures, and those are going to be ossified within weeks. So they have to put a cochlear implant in as soon as possible before the cochlea ossifies, because once you have complete ossification within the inner ear structures, it's impossible to insert the cochlear electrode in the inner ear. You have to do it before you have that. And if you have enhancement on MR and signal loss on T2, that's kind of an indication that you actually have still time to do that. So that's, believe it or not, the correct answer is the cochlear implantation on this one. And again, that's why we have to image those kids within a few days. If they are asking for an MRI with contrast for, you know, potential labyrinthitis ossificans, we really have to schedule it as soon as possible so that we have the images and we have those imaging findings. They have to schedule cochlear implantation very soon too. Just to show you the CT finding, the corresponding CT finding, that's kind of the end result, and that's what we don't want to end up with. If you end up with this image, again, you cannot put a cochlear implant into this thing. So you want to catch those kids before that. And again, most commonly it is after meningitis, but you can get it after any kind of surgery like vestibular schwannoma surgery, prior trauma, and also even after middle ear surgeries, like that's why whenever there are consenting those patients for a middle ear surgery, they mention this as a potential complication as well. So it can happen in many instances, but the most common entity and the classical scenario that you will be asked would be post-meningitis hearing loss. And again, this ossification, go ahead. Somebody was asking something?
No.
Okay, sorry. So as you can see, the density on CT will start to be very hazy, and then it will be completely hyperdense. All right, let's move on to the next one. Next will
be Matthew. He's an R4 from University of Utah.
Okay.
Hey there.
Hello. So 1 second. I'm just gonna.
Okay.
So we're looking at... Yeah. So what we're gonna do here, I will point out to you a few anatomical landmarks, and I'll ask you to name them.
Okay? Oh no.
And we'll...
Okay.
I'm sorry. Yeah, we have to do it at some point. So let's do this. What do you think about that one? The base of the cochlea.
I was going to say the cochlea, but the vestibule.
So vestibule is this kind of cystic structure posteriorly. So if you're kind of looking at that base of the cochlea where you have this kind of bony triangular shaped bone at the cochlea, it has a name.
Modialis.
Excellent. Yes, that is the modialis. All right, so let's look at the neck. So just below that modialis, you have a neck of the cochlea, like kind of an entry opening into the cochlea. Any idea what that is called?
I'm sorry, I have no idea.
It's like an opening aperture.
Antrum?
That's okay. That is cochlear aperture. And we'll have a case that shows why this is so important. So the cochlea has to have a neck. You have to look for the neck of the cochlea. Can you see this neck? I don't know how you can see it or not. Like, see, there is kind of an opening into the cochlea. All right, so now things get a little bit more tricky. So there is this area. Let me go do this. As you can see, there is a lamina that kind of separates the internal partitions of the cochlea. That's called the spiral lamina. And do you have an idea how we call the upper or inferior segment of the cochlear turns? And if you don't know, that's okay. I'll just show it to you. Okay, so the part that is superior is called the scala vestibuli, and the one that is inferior along the base is the scala tympani. And actually, there's a third one, scala media, that we don't see in our imaging. It is kind of a medially, hence the name scala media. So the one at the bottom is scala tympani, and the one at the top is scala vestibuli. And actually, you can see it at each turn. Like at the top, you have the vestibuli, at the bottom, you have the scala tympani. And let's just to show you that I'm not making this up. That's all true. This is osseo-superior lamina. You have the scala tympani at the bottom and scala vestibuli, and you have this kind of in between the scala media. Okay, so I'll just 1 second go over this. We already went over there. All right, so let me show you this case, and I'll help you. Don't be scared. All right, so this is a KISS or Fiesta image, and we're looking to the inner ear structures bilaterally. Yeah. That's the basal turn of the cochlea. And just compare right side to the left side, okay? And I'll keep scrolling, and then I'll show the relevant images. Okay, especially like pay attention to the kind of lateral aspect of the basal turn here, where you can see the scala vestibuli and scala tympani. Look at here, okay? And then I'm kind of
it just seems narrower in caliber.
Correct, exactly. Okay, so at this point normally you should be able to see the lateral semicircular canal, so keep that in mind.
Are there too few turns, like not enough turns?
Not enough turns, that's a good point. How about the semicircular canals? Have you ever seen any semicircular canals?
I don't see
We have the vestibule, yeah. We really cannot see it either. How about the vestibules? Are they?
It's too
do they
large.
look okay?
Too large.
It is. I wouldn't call it large, because the thing is, as you don't have these semicircular canals, they're kind of difficult to pick. But like, how about the internal signal on the right compared to the left?
It's not as T2 bright, but
exactly.
dirty.
So yeah, that's a good word. This looks definitely dirty. Okay. So there is something kind of filling in the cochlea, as you said. We don't see all the turns, and there's something dirty in the vestibule, and we don't see any semicircular canal, by the way. Maybe a little bit of superior semicircular canal here, but we couldn't really see anything on the right side. So just to put those side by side, look at the basal turn here, look at the basal turn here, and then these you can kind of see the separate turns or the separate chambers of the cochlea. Here you don't really see any of it. Okay, so well, it's kind of hard to just talk about this without talking about the diagnosis. But let's first talk about the diagnosis. What do you think is going on here?
I have no idea. I've never seen it.
That's okay. And that's what I mentioned. Some of the cases will be very challenging. Some of them will be very straightforward, but that's why I wanted to show them to you, because you might have occasional very hard cases too. So this is again an example of labyrinthitis ossificans. You know, when you have ossification of the inner ear structures, filling it with stuff, and that's why they are dirty with all those inflammatory cells, and then they become ossified, and you see it hyperdense on CT. And this entity always start with the scala tympani, and that's why I wanted to show the anatomical images first. So scala tympani, remember, it's at the base, and that's what I was trying to show you here. See, you see those kind of two chambers here, scala tympani and scala vestibuli. However, here on the left side of the scala tympani, the bottom part is completely wiped out. There isn't any fluid in that anymore. So that's how the labyrinthitis ossificans starts. It will first involve the scala tympani of the cochlea, but that's not the first structure to be involved, and the first structures to disappear on those T2 weighted images, and then the cochlea will start getting involved, and that starts at the scala tympani, and that's how a normal cochlea looks like. You should be able to see all those different chambers. If you don't see them, there is something filling them. Okay, and of course the diagnosis is, again, it was labyrinthitis ossificans. All right, thanks for doing this case. I know it was a tough one. Let's do the next one.
All right, next gonna be Francis. He's R4 from MGH.
Okay.
Hi.
So this is again a tricky case, you know, and don't feel bad about it. If you get it, that's wonderful. But if you don't, I've I've seen this missed by so many radiologists and even neuroradiologists. So, but this is probably one of the two most common things you might be asked, especially in a pediatric temporal bone imaging. Okay, so
Okay, 13-year-old.
13-year-old.
Bilateral sudden sensory neural hearing loss.
Right, so that's a little, maybe a little bit misleading, but we'll see. Okay, what do you think? Once you see it, you will not be able to unsee it, but it's maybe a little tricky to see it at the beginning.
Multiple heavily T2 weighted images. There's enlargement of the vestibular aqueducts bilaterally.
Excellent. Perfect. By the way, we try to avoid the term aqueduct on MR because you don't really see the aqueduct, but you see the endolymphatic duct and sac that is in it on MR. So if you're describing an MR, just use the term endolymphatic duct and sac and not vestibular aqueduct. But that's a great pick. And let me show it to other people who may not have seen it. So this is, this is the abnormality here. That it has enlarged endolymphatic duct and sac bilaterally. And why is it so difficult to see? Because, well, sometimes you just think that this is part of the posterior fossa CSF as it's kind of surrounding the vestibules, but it's a great pickup. Wonderful. So the question is even more challenging. Which one is false for the diagnosis? Do you think this one has often associated inner ear anomaly? Is it the most commonly detected inner ear anomaly on imaging? Does it present with congenital hearing loss? And does the headache or hearing loss worsens with trauma? Which one is false?
D.
So D is correct. Those kids actually got kind of a worsening hearing with each head trauma they get. That's why they are usually prevented from doing contact sports. Some of them will wear helmets whenever they're doing any kind of exercise. So that's correct. Pick another one. Remember, how old was this kid?
Forget.
It's okay, I can show it to you.
13.
And had presented with sudden hearing loss. So that is not correct. Correct. So, and that's very tricky because it is a congenital inner ear anomaly for sure. But those kids are born with normal hearing, and that's why they pass the neonatal hearing test without much problems. However, in life, with each head trauma that they get, with each kind of intracranial pressure that they acquire, there is kind of a stepwise decrease in their hearing. And that's why parents do not notice it until it kind of hits one threshold, and then suddenly they notice, oh, this kid is not hearing well. And that's why they may present as an adolescent with sudden hearing loss, and that's not a rare entity. And that's kind of also a typical history that you might get, you know, an adolescent with sudden hearing loss, but actually there is an underlying congenital inner ear anomaly. And that's what it is. It's enlarged vestibular aqueduct on CT. And that's easy to pick on, I mean, I should say easier. You just compare the vestibular aqueduct with the adjacent lateral semicircular canal. It shouldn't be larger than the lateral semicircular canal. If it's large, that is abnormal. It is very frequently bilateral, as you can see here. And on MR, you will see endolymphatic duct and sac dilatation, as you can see over here. So if we go back to the question, it really has almost always associated inner ear anomaly. And the most common inner ear anomaly that it has been associated with is a kind of a rare, I shouldn't say rare, but not frequent inner ear anomaly. However, if you look at all those inner ear anomaly, this is actually one of the most frequent ones, although this is still a rare entity. So that is not something hopefully you'll be asked to, but if you are asked about any congenital inner ear anomaly, it's going to be either enlarged vestibular aqueduct, type 2 incomplete partition, and one other one that I will show you next. The other name for this anomaly is maybe more familiar. It's called Mondini anomaly. But the thing is, more and more people are trying to avoid this term Mondini because it has been misused for so many times by so many people. That's why the correct labeling, the correct term nowadays is this. So if you get a kind of a newly written question, that's what term you'll get. What is the typical feature of this anomaly? It's well illustrated by this diagram. That's the normal inner ear, and that's an abnormal inner ear with IP2 anomaly or Mondini anomaly. What you'll see will be the cystic dilatation of the apex. You'll have a cystic dilatation of the vestibule, and then you'll have enlargement of the endolymphatic duct sac. Those three things. cystic apex, large vestibule, dilated endolymphatic duct and sac. And actually, that might be the only thing you pick up on the imaging. You know, on MR, on CT, that may be more obvious. But then if you look very carefully, you might detect the second anomaly. Okay, so endolymphatic sac dilatation, again, on CT, MR, and there's almost always an inner ear anomaly. Again, cystic apex would be the kind of easier thing to see. All right, that was a challenging one. Thanks so much for taking it. All right, let's go to the next one.
Next going to be Asra. She is R4 from University of Oklahoma.
Hi, Dr. Ozgen.
Right. Hello. So again, a tricky one. But hopefully I gave you already a few tricks that might help you. So this is a very small kid. And again, coming in with very severe sensory neural hearing loss since birth. So you know it's kind of a congenital hearing loss problem that you will have to deal with. All right. So let's look at those axial CT sessions. And then try to decide if you don't see any anomaly, that's fine. And hopefully you'll learn from it. And if you do see it, now is the time. You see anything abnormal?
Okay, so you can hear me, right? Okay, so I don't think that the vestibular aqueduct is enlarged. I think that is normal. Looking at the cochlea, at first I thought they're a little big, but I think in order for us to call partition anomaly, the vestibular aqueduct has to be enlarged. So I'll let the cochlea be. I think it's okay, and I see the medallus. Then
let me help you. Can I help you?
Yeah.
What do you think about the IAC? I haven't shown the entire IAC, but if you look at here.
Yeah, it looks abnormal. It's not like that. Yeah, it looks like it's stenosed. Like it's not
correct. It looks narrowed. Okay. And one more thing, when we are going over the anatomy of the inner ear, remember we talked about modilus. Here it is.
Yeah.
And then I mentioned that you had to see something beneath it, under
the aperture, the cochlear aperture is also very stenosed. Yeah.
Correct. You don't see it well, do you? Okay, no. That's excellent. So the question is going to be, what do you think is the next best step?
Okay, so I would say urgent surgery.
No.
Well,
that's okay, you know. The thing is, whenever we don't see the neck, the thing that I or any ENT surgeon would worry about is, okay, this kid obviously coming in with hearing loss, so they want to improve the hearing. And whenever you do not see the neck, it may mean that the nerve that normally courses through that neck may be absent. So you need some kind of imaging to see whether or not there is a nerve anomaly with it. That's why MR should be the next step. Urgent surgery should be done within the first 2 years, ideally. With those kids who would have congenital hearing loss, like cochlear implantation or auditory brain implantation, they have better prognosis when they're done within the first 2 years, but it's not really urgent. You know, you can still plan and make sure you are doing the right thing. Why is MRI so important? Because with this anomaly, where you have kind of aperture stenosis, the cochlea itself can be completely normal. So technically, they can easily put a cochlear electrode in without any problems. That wouldn't be a problem. But if there's no nerve, it will not work properly, because there's not going to be a nerve to transmit the electrical stimulus sent by the implant. And that's why whenever you have cochlear aperture stenosis or atresia, and by the way, that's how a normal cochlea should look like with a normal neck. So whenever you have this obliteration or narrowing, you have to recommend an MRI to look for the nerves. And I will just show you the nerve, actually absence of it. As you can see, the IACs are very narrowed here bilaterally. And if you do those sagittal oblique images, normally you should have seen 4 nerves in the IAC, as you remember, and you can see a single nerve, which is typically the facial nerve in this instance. You don't have any vestibular nerves, any cochlear nerves. So that was a cochlear nerve aplasia as well. The cochlear implantation cannot be performed. It's actually contraindicated. So the only option this kid has is auditory brainstem implant. And that's the study that tells us that this big distinction. That's why the next step should be an MR. Thank you so much. It was a difficult case.
All right.
All right.
Let's Omar. He's an R4 from University of Maryland.
Hi, Omar. Okay.
Hello.
That's easier compared to the other one. So you got lucky. All right. Have a look to the images. And then I'll ask you, what do you think this is?
Okay.
So I'm going to go with C, autosclerosis.
Excellent. Okay, let's briefly go over the previous image together. So as I told you, the otic capsule, this kind of bony island here, is one of the toughest bone in the body. That's why it should be uniformly hyperdense. It should be this density everywhere around. If you see areas that are kind of a little bit washed out, a little bit gray, that is abnormal. It means that there is something affecting that bone. Actually, it is transformation to an autospongiotic bone. So the correct term is autospongiosis, but we're kind of stuck with the term otosclerosis, which is kind of the second step where you have new bone formation in this area, obliterating the oval window, causing kind of stapedial fixation, hence the hearing loss. So what we had, we have two options. It can be either an otosclerosis limited to this area here, this area, which is called fistula antefenestrum. And as you can see, this area should be uniformly hyperdense as elsewhere in the otic capsule. If you have any lucency here, that's a fenestra otosclerosis. Or actually, this lucency can be also seen posterior to the cochlea or in the retrocochlear areas, in which case you will end up with a retrofenestrial otosclerosis. It can be this kind of complete ring, like another turn of cochlea, but sometimes it's just could be just patchy hypodensities. And that was the case in our example. Like you have the fenestrial otosclerosis here, but there's definitely some patchy hypodensities behind the cochlea. So this one was fenestral and retrofenestral otosclerosis. And for the fenestral part, it may not always be very obvious. So just any radiolucency here compared to the remainder of the capsule should make you think about otosclerosis. I have one more very helpful clue. The presenting patients usually are very typical. It's going to be a woman in her 20s and 30s presenting with mixed hearing loss. So if you have those in your question, like women in 20s, 30s presenting with mixed bilateral hearing loss, you know the diagnosis even if you don't see the images at all. So always remember that. That kind of patient presentation cannot have anything else. You should pick otosclerosis in this instance. All right, let's move to the next one.
All right, next gonna be Christian. He is R4 from University of Utah.
Okay, hi Christian. So this is gonna be, and again, anatomical question, believe it or not. So this is the patient. He has, unfortunately, adenoid cystic carcinoma of his soft palate, and he's presenting with a pain in his left V2 distribution. And those are the images, and I was very helpful. As you can see, I put an arrow on it. So have a look. Yeah. And I'm gonna ask you an anatomical question. I'm gonna ask you, what is that structure I pointed to with the arrow?
That's the foramen rotundum.
Excellent. That's exactly what it is. Okay, so let's go over this case again. So the things that can be appreciated, let's first look at the CT. So that's the normal bone marrow of the sphenoid bases, and you can see that there is some sclerosis here. There might be a little asymmetric enlargement of the foramen rotundum, but not that obvious. You have the Vidian canal below it that also may be a little bit of enlarged, but not that obvious. Now let's look at the MR images. This is a T1 weighted image, and instead of the normal bone marrow, you have the evil gray, as Dr. Curtin would call it. The evil gray, you're placing all that bone marrow, and you have also better delineation of the foramen rotundum, which appears larger than on the right side. And on the post-contrast images, as you can see, there is definitely asymmetric enhancement. So again, going back to the anatomy, foramen rotundum is the one that is superiorly located of the two holes in here. The inferior one that may be better seen, especially if you have a pneumatized vitreous basis, will be the Vidian canal. Rotundum up, Vidian V bottom. Here you go. Okay, he puts lots of arrows. Okay, so we'll keep going. That was an easy one. So how about this one? This is again patient with adenoid cystic carcinoma presenting with perimandibular paresthesias. What do you think is going on? Have a look, and then I'll ask you the question.
Yeah, I'm looking at the left picture, the corona T1 post at the level of the skull base cella. And there's an asymmetric enhancement.
Excellent.
Along the left side of the cella skull base. And I think it's the foramen ovale.
Okay, that was my question. So this is again an example of perineural tumor spread, obviously, where you have this enhancement extending along the nerves going intracranially. And indeed, that was through the foramen valley. And here you can see this asymmetric enhancement on the axial images too. So that was your foramen valley. And again, with the foramen valley, we always use that nice shaped shoe, right? The kind of the heel is the foramen spinosum and the base is the foramen valley, oval shape. But I like to find it on the coronal images. So if you look at the coronal images, the kind of a big opening that you have along your middle cranial fossa going to the infratemporal fossa are going to be your foramen valley on each side. Okay, excellent. And again, just delineation, nice demonstration of foramen valley and the V3 that goes into it. So I'm just going to show you two nice diagrams that really help me to better understand what goes through what. So if you look at the trigeminal nerve, of course, you have the three branches, V1, V2, and V3. And then what goes through what? The V1 goes through superorbital fissure, V2 goes through foramen rotundum, and V3 goes foramen valley. The other important landmark is pterygopalatine fossa, and you can see how a lesion that somehow reaches pterygopalatine fossa can easily extend through the V2 and through the foramen valley all the way to the brainstem by perineural tumor spread. All right, so let's move to the next case.
All right,
This
next
is kind of a, go ahead.
Next will be Amin. He is R4 from UCSD.
Okay, I mean, all right, let me show you a very ugly case.
Hello. So here on the axial CT, we see a lytic lesion centered
Skull base.
skull base, yeah. So
Let's make it
I
easy
think
for
it's
the
in
moment.
the clivus. Yeah, it's centered in the clivus.
Excellent.
On the flare sequence, there are foci of T2 bright in the
I
area.
think it's T1.
Oh, it's T1. Okay, sorry. Yeah, yeah, it's in T1. And then on T2, it is T2 hyperintense. And then centered in the clivus, extending to, yeah, so it looks like it's chordoma.
Excellent. And that's basically, this is the only image you need to remember about chordoma. That is a chordoma. And I will give you a few more tricks, but just try to memorize this image. It will look just like that. It will be centered at the skull base, located centrally, not off midline. It will be very bright on T2, and typically it has this kind of a grape-like, multi-cluster-like appearances that is very, very typical. So it will be centered at the sphenooccipital synchondrosis, and then if you look at the sagittal image, it's going to be a kind of a middle cranial fossa mass centered at the clivus, upper aspect of the clivus. Again, you know, it can have very heterogeneous enhancement, but the very helpful feature is the T2 hyperintensity, and especially this image. It can be also kind of a more iso-intense, but typically this is the image that you will encounter with chordomas, this kind of multi-lobulated, multi-clustered appearance. Again, the enhancement, you may not see any, or you can see evident enhancement. It's not helpful at all. Always think of that multi-lobulated clusters. That's what I think it looks really like those fish eggs. So when you see something that looks like it at the skull base, go for chordoma always. Another helpful feature that we always talk about is the thumb sign, right? So if you have a lesion that kind of more dorsally in the clivus going into the prepontine system, it kind of pushes the pons like a thumb would push it back. And if you see that image and kind of a midline sagittal image, again, think of chordoma. Okay, let's move to the next one.
All right, next going to be April. She's R4 from University of Utah.
Hello.
Okay.
So that might be a little easier after the previous one.
Yes, so we have T1, T2, and T1 post contrast image through the skull base. We have a T1 bright and T2 bright lesion.
T2 and KISS. I'm so sorry, I interrupted you, but there's no T1 here. Just okay, the KISS or Fiesta sequence and T2.
Yes. And I think that this is probably a chondrosarcoma.
Exactly. Off midline, bright on T2 enhancement, you have to go with chondrosarcoma. Excellent. So again, what are the kind of helpful tricks with chondrosarcoma? Off midline location, right? Centered at the petrooccipital or petroclival fissure would be typical. calcifications on CT. I haven't shown you the CT, but like this kind of heterogeneous calcifications, and T2 hyperintensity. Those three things, if you can check all three, you have a chondrosarcoma. The enhancement can be variable. I like to always mention that you can have polka dot-like enhancement on those, but that's not an absolute must. It can have also more heterogeneous and homogeneous enhancement. All right, let's do the next one, which is somewhat easier.
All right, so next gonna be Laith. He is an R4 from University of Oklahoma.
Okay, you got lucky. All right, let's see.
Okay, we have a 30-year-old male with headache. Have a CT, a T2, and a T1. Looks like there is a lesion in the petrous apex that is T2 bright and T1 bright. So there might be some hemosiderin deposition in the on the T2. So I'm thinking that the first differential would be E, cholesterol granuloma.
Excellent, that's exactly what it is. And of course, the clues to the diagnosis are, first of all, expansile appearance on CT, right? That's why it's not asymmetric bone marrow signal. You had expansile lesions. If this was just asymmetric pneumatization, you wouldn't have had this kind of expansile appearance on CT. And the second most useful thing is pre-contrast T1 shows you bright signal on T1. So T1 hyperintense, expansile lesion, petrous apex, you know what it is. This is a cholesterol granuloma. It can be unilobular as this case over here, or multilobular, doesn't matter. As long as it's expansile and hyperintense on T1, go for cholesterol granuloma. Somebody had asked me once, why not cholesteatoma? Cholesteatomas will never be bright on T1. Okay, if you see T1 hyperintensity, that is a cholesterol granuloma, not a cholesteatoma. Okay,
all right.
That's a difficult case. I have to warn you.
This case is going to be Jisoo. She is from Brigham, R4.
Okay, I'm glad it's an R4. All right, so this patient comes in with ear pain, deep kind of neck pain, severe headache. Let me leave it as that.
I see. So we have T1, T1 post, and T2 axial images through the level of the ear. What stands out is the asymmetric fluid on the right.
Okay. Oh, by the way, I forgot to tell you, he is diabetic.
Okay.
That might help you.
I'm thinking malignant external
otitis external. Okay. So typically, there is a kind of a terminology confusion here, but when we talk about malignant otitis externa, usually, as the name implies, it should be much more or less limited to the external artery canal. If things have moved on, as in this case, more towards the skull base, there is maybe another term for it. Can you think of what it might be called? How about now?
Skull base.
Osteomyelitis,
yeah,
right? And it's not wrong to call it malignant otitis externa. And again, that is not very clear in literature or if you go online. But typically, I try to use the term malignant otitis externa. And by the way, it's not a good term, right? It's not malignant. So, but that's usually when you have an inflammation that kind of went a little bit too aggressive in the soft tissues around the external artery canal, kind of going to the retrocondylar area. But if you have signal changes going all the way to the skull base with accompanying bone marrow signal changes, you should actually call it skull base osteomyelitis. But you did great. The most important issue here is to distinguish this thing from all the other malignant infiltrative processes. And believe me, it is not easy. I've seen so many great neurologists miss this diagnosis occasionally. So I think what you will get is definitely going to be very specific patient group, like diabetic patients presenting with, otorrhea, some cranial nerve palsy, especially like 7th nerve palsy, and pain. Usually there's almost always accompanying pain. So what are the very important features regarding this patient? So on T1 weighted images, if you only look at T1, this can look like an infiltrative aggressive process, but look at T2. On T2, everything is where it's supposed to be. There is no displacement of any structure, but just some signal changes everywhere. And again, look at the post-contrast images. There's nothing that expands, that infiltrates, but just signal changes that kind of still follows the kind of boundaries of the facial plane. So that's a very important helpful feature. Look at the retrocondylar area, or TMJ. There aren't any malignancies that I know of, especially of skull base or nasopharyngeal carcinomas, that will involve the TMJ. So if you have this signal changes involving TMJ, you have to think about something inflammatory. And the third helpful feature is actually something that is better seen on this patient. If you have accompanying dural sinus thrombosis, think of skull base osteomyelitis rather than all those infiltrative processes. Nasopharyngeal carcinoma, skull base masses, they rarely cause dural sinus thrombosis. However, skull base osteomyelitis very frequently causes dural sinus thrombosis. So if you have TMJ involvement, dural sinus thrombosis, and again, if you have kind of preserved facial planes on T2 and post-contrast, think of skull base osteomyelitis. I'm just going to show you what I mean by this expansile feature. So this is, for example, a nasopharyngeal carcinoma, and that's a lymphoma. See how you see this expansile mass lesions? However, here, there isn't such a thing. There are signal changes, yes, but nothing expansile infiltrative. Okay, hopefully that will stay with you. Okay.
All right. So
fun case.
This is going to be the second round. So we will be back to the first person, Grace.
Hey.
Okay. Welcome back. All right. This is kind of a challenging but fun case. I really want you to look at everywhere, at every corner of those images.
Okay, sure. So
Elmira probably knows about this case. I always show this case to everyone I see. Okay, go ahead.
Okay, so we have a T1 sagittal and we have a T1 post-coronal. It looks like we have looks like a T2 coronal and a T1 post axial slice. And we see this, multi-spatial mass kind of centered in the nasopharynx, and it's extending into the skull base just below the frontal lobes. And we also see
let me interrupt you. When you said nasopharynx, actually on the sagittal images, nasopharynx actually is separate from the mass. It's more kind of a skull base.
Oh, okay, so skull base mass, got it. Okay, thank you. So we see a skull base mass, and it's kind of extending laterally along the skull base, and then also we see another focus along the calvarium on that right side.
Excellent. Yes, that's what I wanted to see. Perfect. Okay, they're not connected.
So I would say on T2, it's like heterogeneously hypo-intense, and T1, it's kind of iso-intense. And then it looks like it is enhancing with areas of non-enhancement centrally. So I would say this is like an aggressive mass, like some sort of malignancy. I kind of wonder, I don't see like any peritumoral cysts. Like I guess one thought it's like something in this area, I would think about like enthesio neuroblastoma. But
okay, however, don't forget that you have 2 lesions. Which isn't typical for olfactory neuroblastoma. So 2 lesions.
2 lesions. So I guess this could be like a metastatic lesion.
Okay, excellent.
Coming from another primary into both sites.
Definitely. But then I'll ask you to look at the T2. Look how dark this T2 signal compare a normal looking calvarium.
It
looks as
very similar.
Similar, exactly. So anything infiltrative shouldn't really be that similar, should it? This is extremely fibrotic or sclerotic.
Okay. Could this be kind of, I mean, I maybe we could get like a CT scan to see what it looks like it.
Yeah, exactly. And that's what I would definitely do. So if I had asked you which one this could be, not meningioma, obviously it's centered into the bone and you don't have any dural tail or any extraaxial component. Not a sinonasal carcinoma, it's really dark on T2. We discussed this is not going to happen. Plasmacytoma, again, too dark on T2. MET would be a good thought, but again, it's just way too dark and it's very similar to the calvarium. So I would definitely get a CT. So the answer is none of these. And let me show you the CT and you'll get the diagnosis right away.
Yeah,
that's a fibrous dysplasia. Yeah, so Elmira really knows about it. And that's a very illustrative case of how awful as fibrous dysplasia can look on MR. It will look like an expansile, infiltrative, heterogeneous mass. But really the clue to the diagnosis, first of all, if you can see more than one bone involved, then that's very helpful. And then the T2 signal. No malignant tumor in its right mind would show similar signal changes to the bone. It wouldn't be the exact same density. We know why it looks the same, right? Because it is basically kind of sclerotic bone. So keep that in mind. If it's very dark on T2, if you have multiple lesions, that might be a fibrous dysplasia. Okay, but in all honesty, I don't think nobody will ask you the MR. They hopefully will only ask you the CT, but I think that's a good case to kind of show how if, for example, if they show you CT and MR shouldn't convince you that this is something else. Okay, stick to the what you trust with your CT. Okay, so I'll just go over the next one.
All right, Prashan,
that's an easy one.
Green screen.
All right, 1 second. Oh, it's stuck. Oh, here you go. Okay. Not giving any symptoms because that's what I'm going to ask. I'm going to ask you what is the presenting symptom in this patient. I know they're not the prettiest images.
Let's just orient myself. So there's some asymmetric signal. So this is
oh, sorry, it's a post-contrast T1, both post-contrast axial and coronal T1s.
Okay, so we're at the level of like the skull base, and it looks like there's asymmetric enhancement in the what looks like the is this the horizontal portion of the internal carotid? Or
so yeah, I know I should have put a T2, but I didn't have a corresponding one. So this is the cochlea here.
Okay.
And here is your cochlea here. So right. There is an enhancement just kind of posterolateral to the cochlea that forms this kind of reversed V shape.
So
okay, maybe if I ask you the question, that might be a little bit easier.
So the patient's presenting symptom in the setting of some enhancement around the cochlea.
And again, reverse V is the trick word here. Coming in and going back.
So will they have like a facial palsy?
Yes.
Like a Bell's palsy?
Exactly, exactly. It was too easy other ways. The way I had to ask you a different way. This is Bell's palsy. And the important thing that I want to point out here is that you can make the diagnosis of Bell's palsy when you see enhancement in the canalicular or labyrinthine segments of the facial nerve. If you see enhancement in the tympanic segment or the horizontal segment or the descending mastoid segment, that is not abnormal. That's the normal appearance, appearance of a post-contrast appearance of the facial nerve at this location, because there is a kind of a circumneural venous plexus that normally enhances post-contrast images. So you can only make that call if you see enhancement in the canalicular and labyrinthine segment. So if I ask you which segment of the facial nerve cannot enhance in a normal patient, that the answer is going to be canalicular and labyrinthine segments. The other segments can enhance in a normal patient as well. Okay. Thank you. Let's move on.
This is going to be me.
All right. So you got lucky. 30-year-old boy, bilateral visual field deficit, panhypopituitarism, and I will give you a few more images. Keep looking. So that was T1 pre, T2, sagittal T2, kind of keep circle, and that will be the most helpful image ever.
So, okay, a cystic mass in the cella, expanding it, and I'm not sure I can see the pituitary gland itself. I'm playing along. So it's got to be craniopharyngioma.
Yes, cystic calcification, you have to go for craniopharyngioma. You're absolutely right. So what are the other additional features about craniopharyngioma? Of course, the age distribution, right? You have a kind of two peaks, one in 10, 14, and then one after 40s. The MR appearance will be, of course, kind of a multilobulated cystic lesion, and usually that cystic component has kind of a very dense viscous component. That's why it will be bright on T1, very bright on FLAIR images, so that may be very helpful. The CT shows best the calcification, but if they give you a gradient echo or susceptibility weighted imaging with focal blooming, that's the same thing. You know that there is calcification in those lesions. And again, it can be very heterogeneous on some cases, but nevertheless, cellular supracellular mass, cystic component, calcification with the right age group, go for craniopharyngioma. Okay. How about this one?
It's you.
Hey, so we're getting coronal images, coronal MR images. Looks like it is post-contrast on the left and T2 on the right. Sorry,
Right, so
radiology,
T2,
right?
T2, post-GAD coronal, and regular T1 side.
And there's this dumbbell-shaped mass that's kind of in form plate. I'd love to see some adjacent cysts nearby. I don't think I can identify those.
There is edema, which, you know, you can use your imagination and think that it's a little bit cyst.
Okay, but this is the esthesionioblastoma. I've never had to say that loud.
Yeah, me neither. I usually go for olfactory neuroblastoma, much easier.
Okay.
But again, the kind of imaging findings are very, very helpful, as you pointed them out excellently. So typically, those tumors will arise in the superior nasal cavity and then go intracranially with cribriform destruction. And as you can see, it can be purely intranasal, and that's fine. And that would be a very difficult diagnosis in this instance. But if they can go, sorry, I moved on to the case. Oh, what happened to my other one? I had another additional image that I must have deleted. Anyway, when it goes up intracranially, you will usually have this cystic component. I have to tell you, for your daily practice, not for the boards, this is not the only tumor that can have accompanying cysts. Sometimes meningiomas can also have those cystic changes. But for the boards, if you have kind of an anterior cranial fossa mass going from the nasal cavity intracranially with accompanying cysts, it has to be olfactory neuroblastoma. Great job. Okay. Let's do the next one.
Francis, you're next.
Okay. So the abnormality is at the right jugular foramen. There's a pacification of the right middle ear cleft, pacification of the mastoid, and this mass at the jugular foramen that causes a permeative, erosive appearance to the bones surrounding the jugular foramen. Potentially extending into the middle ear cavity. I'm not sure whether that's mass or just fluid. And so this would be typical of a paraganglioma.
Excellent. And probably it is even going out of the ear. See, there is an enhancing component in the external auditory canal. So kind of not only it went into the middle ear cavity and then it went kind of laterally, but that's exactly what it is. That's a glomus jugular tympanicum. So sometimes it may not be so easy to decide whether jugulare or a jugular tympanicum if there's a small extension into the middle ear cavity, but this one was definitely going more superiorly than it should be. You pointed out the imaging findings very nicely. The permeative erosion at the skull base, I think that's a very helpful feature. That's not what you're going to get with the other things that can be located in this location. It's kind of permeated erosion, great. Avid enhancement on post-contrast images. CT or MR doesn't matter. Glomus tumors are one of the most vascular tumors that exist, so they'll be showing avid enhancement, both CT and on MR. And again, one of the things that we as neuroradiologists and head and neck imaging are more concerned about is sometimes you can only see the kind of middle ear component of glomus tympanicum, and it's very important to be able to tell the surgeon that this actually, whether or not this is purely in this location or does it extend to the jugular foramen, because if that's the case, it becomes a much longer and more extensive surgery with much higher morbidity. That's why from our point of view, the other way around is much more important. If you have a lesion here, does it go back inferiorly? And then basically you have to look to the jugular plate here. Is it intact or not? If there is resorption there, there is clearly extension to the jugular foramen. Okay, and again, for imaging, the kind of typical features to remember are the salt and pepper images, salt dots on T1, dark pepper dots on T2, salt and pepper, related to hemorrhage and flow voids. And again, very avid enhancement, whether it's on CT or MR. Okay. And that's again a very good delineation of like glomus jugulare or paraganglioma extending into the middle ear cavity nicely. All right, and this was also the MR in the case that I had shown you. All right, so let's go to the next case. Thank you.
Next gonna be Asra.
Okay, Asra, not your lucky day. That's a more difficult one. Okay, let's have a look.
Okay.
So let me post-contrast fat set axial, T2, post-contrast coronal. And this is actually a post-contrast CT of the same patient.
The same patient. Okay, so the first image shows a mass lesion, which is traveling down the jugular foramen.
Okay, so similar to the prior one, right? Same location.
Similar. Yeah. Okay. So I'm thinking schwannoma.
Okay, let's go step by step. So enhancing lesion in the kind of jugular foramen, and as you pointed out, it kind of goes inferiorly to the neck, a little extracranial soft tissues. Yeah. You're absolutely right. Okay, what do you think the CT image is helpful for?
To localize which compartment it is in.
True, and furthermore, this
which space it is in, and what it does to the bone adjacent to it.
Definitely, but to me, it's most useful to show the lack of enhancement, right? Okay. It's a post-contrast CT. It doesn't light up that much.
Yeah.
Which kind of helps you in kind of ruling out what one entity, which is what? The one we just saw.
Yeah, the paraganglioma.
Exactly. No paraganglioma in its right mind would give you this post-contrast image. You know, it would light up like light bulbs. So that tells you that this is not a glomus tumor, and you are absolutely right. After this point, you are stuck with the other options you get at jugular foramen, which is usually, you know, peripheral nerve sheath tumors. One thing that could help you is maybe this image. See, this is kind of the bottom part of it, and then you have this kind of intracranial component. What do you see here?
Like a dural tail to it?
Yes. So if I ask you what it is, and I don't put schwannoma there on purpose. Meningioma would be the, but I think your reasoning was perfect. You know, this is clearly not a glomus tumor, so it has to be one of the other ones. And especially with the dural tail, which was more subtle, this is a meningioma. So again, always in this location, you have to think about meningioma as well as a differential diagnosis. And again, if you put the glomus tumor with this meningioma, you see the differences in enhancement. That's how a paraganglioma should enhance, and that's how a meningioma or a schwannoma would look like. Okay, I'm just skip those. Thank you.
Thank you.
Okay, Omar is next.
All right, let's see this one now. Now it will be easier because of the previous ones we have seen.
Okay, so we have T2 top left, T1 pre, T1 post without fat sat, and T2 coronal and CT. And it looks like there is a mass, an enhancing mass centered on the right petrous apex.
It's a little bit lower. It's actually similar to the ones we just saw. More kind of a jugular.
Yeah, I don't see salt and pepper appearance, and it looks like homogeneously enhancing. As far as the osseous, it looks like, yeah, it's not like doesn't have aggressive or primitive erosion, more from expanding the osseous structures compared to the other cases that we saw.
Okay, so what do you think this is?
Gonna go with a schwannoma.
Excellent, yes. And again, the clues, the location is one thing. Of course, the fact that it's homogeneous and the scalloping on CT. You know, see how nicely it behaved towards the bone. It pushed it out very nicely, and then it's also very nice. It's very homogeneous. Having said that, schwannoma, as they increase, they can become more cystic. So that's not always a must. But typically, the case you will be shown here for jugular foramen schwannomas will be homogeneous with expansile bony changes, as you have already seen. Okay. So the next one is a little bit more challenging, but it has a very specific diagnostic feature. So that hopefully that will help you.
Okay, Christian, go for it.
So I see that mass in the posterior aspect of the petrous bone.
Oh, by the way, this is a pre-contrast T1, just so that I don't forget it. So you have a CT and a pre-contrast T1.
As a primarily, it has high signal on T1, so it could be blood or highly nice cartilage.
Okay, and I will let you just think about what it is and show you that I'm not going to ask you that. I'm going to ask you its association. That might actually help you with the diagnosis as well.
Yeah, it's just a guess. I think it's some endolymphatic sac tumor.
Yes, excellent. I know it's a tricky. And von Hippel-Lindau disease, it's when you can see it. And actually, you can even see it bilaterally in von Hippel-Lindau cases. So that's very important. And that's one of the things that I was taught at MSI is that if you see any T1 hyperintensity at the vestibular aqueduct or endolymphatic duct on MR, you should always contemplate a diagnosis of endolymphatic sac tumors. A tiny one will still show focus of T1 hyperintensity on pre-contrast images. So that's important to bear in mind. What are the features that are very specific? The CT appearance, right? Posterior aspect of the otic capsule and kind of centered at the vestibular aqueduct region with this kind of multi-loculated honeycomb appearance, and then T1 hyperintense parts that are T1 hyperintense on the pre-contrast T1 weighted images. So again, a honeycombing is very, very typical. Look for that on CT. And if you have T1 hyperintensity, then you know what this is. Okay, excellent.
Could it be also like as a differential a venous vascular malformation of the facial nerve?
Yes, so I was, well, I was going to show you a case of that, true, but so typically venous vascular malformation of the facial nerve will be centered at the facial nerve. As you can see, this is kind of eccentric to it. You can see the facial nerve intact and separate from it. Could you have any venous vascular malformation in this location? Why not? But I haven't seen any so far. Everything that I've seen at this kind of posterior aspect of the otic capsule, just sitting where a vestibular aqueduct will sit like, you have to go for endolymphatic sac tumor. One thing that I've seen that looked somewhat similar was a renal cell carcinoma metastasis. Remember that renal cell carcinoma metastasis, as papillary thyroid carcinoma metastasis, they tend to be very hypervascular too. So that was the only thing that I've seen that looked similar to this one.
Okay, thank you.
All right, next going to be Amin.
Sorry, okay, here we go.
Yeah. Okay, so we have a T2 and a T1
post
T1 postcon on the right side. Okay, so there is a complex heterogeneous mass that is cystic in part, centered in the perimesencephalic space,
but
CSF space.
No, you're absolutely right. But you have to realize that this is kind of a dumbbell-shaped thing, and it's the center of it is really would correspond to this area here. What is the structure here on the other side?
Meckel cave.
Excellent. Okay, so mostly centered to the Meckel's cave.
Meckel's cave. So it's in part cystic and partly solid. That's enhancing. So it can be a trigeminal nerve lesion. So
like what?
So glomus, no. Schwannoma, it can be. Lymphoma, no. Meningioma, no. Metastasis, no. Yeah, I'll go with schwannoma.
Schwannoma. And this is one thing you have to remember about fifth cranial nerve schwannoma. That's exactly what they will look like, especially when they are large enough. That is so typical. The location centered at the Meckel's cave, dumbbell-shaped appearance, and cystic changes. For some reason, the schwannomas who happen to be there are more often cystic and heterogeneous than homogeneous ones. So if you have a cystic kind of heterogeneous lesion centered at the Meckel's cave, having this kind of dumbbell-shaped appearance going backward, think of fifth cranial nerve schwannoma. Okay, again, see different other examples or very similar. Centered, dumbbell, cystic changes. Okay, we're coming to the end. So let's go back to our temple bone. Chronic otitis media has otorrhea and conductive. Who's taking this one?
April.
Okay.
So, so I think we see a soft tissue mass that is in the inner ear, and it's eroding the ossicles. So I'm wondering if this is a cholesteatoma.
Okay, but that's not good enough. What kind of cholesteatoma it is? I know, I'm not making it easier.
I am not sure.
That's okay. And actually, the clue is the history. This is an adult male, okay, and has history of chronic otitis media.
Okay.
So this tells you that this is more likely to be an acquired cholesteatoma and not a congenital one. Congenital one is typically the one that we see in kids. If you have an adult coming in with chronic otitis media complications like otorrhea and so forth, you have to think about acquired cholesteatoma. And those come in two forms. You have pars flaccida or flexida cholesteatoma and pars tensa cholesteatomas. Okay. As you can see, I have only put one of those here.
So the pars tensa cholesteatoma?
Exactly. Okay, that's what it is. So let's quite quickly look at what is the difference. So as you can see, you have two different parts of the tympanic membrane. The upper part, which appears to be smaller, is pars flaccida or flexida. I never know how to pronounce this. But what happens is that whenever you have a cholesteatoma in the Prusak space, it typically will kind of go upward, as in this one. See how it kind of went up. And that's very typical pars flaccida cholesteatoma. They tend to go up and fill the upper middle ear. However, for the pars tensa cholesteatoma, which remember was kind of involving the more inferior part of the tympanic membrane, they tend to go more inferiorly and more medially. And that's why if you have something that kind of is around the more central mesotympanum, kind of cover it, going a little bit to the anterior epitympanic recess surrounding the cochlear promontory, it's more likely to be pars tensa cholesteatoma, especially if you don't have any involvement of the kind of superior lateral part of the epitympanum. And so if it's going more medially, inferiorly, it's more likely to be pars tensa cholesteatoma. Let's look at the other options that we had in the differential diagnosis. Congenital cholesteatoma, again, it will occur in this location near the eustachian tube orifice surrounding the cochlear promontory. The presentation will be different. It's going to be a small kid presenting with conductive hearing loss. So the kind of patient distribution, age distribution should help you with that entity. Glomus tympanicum presentation will be completely different. This will be a retrotympanic pulsatile red mass. Again, pay attention to what you're giving us history. Otherwise, the imaging findings can and do look similar. Of course, the thing about glomus tympanicum compared to the cholesteatomas, they tend to cause less ossicular erosion. Cholesteatomas, by their nature, they really erode into the surrounding ossicles and bones. So if you don't see any ossicular erosion, it's more likely to be glomus tympanicum. But on CT, I have to admit, they can look very similar. Something you may not always see, and it's almost impossible to diagnose preoperatively, honestly, is a middle ear adenoma. This is another pathology that can arise in the middle ear. And this one will be seen as a pinkish retrotympanic mass. So that may be the only helpful. You will never be asked this, so no worries. Nobody in his or her right mind will ask you this at the boards, but just if you have this in the differential diagnosis, it can occur in this location. It will have avid enhancement, but it's not an easy diagnosis preoperatively. And again, this is almost never the right diagnosis. Okay, and I think we are
late. Next.
This should be the last case. Yes.
This is the last case. All right.
Okay.
So we have a sagittal T1, an axial T2, axial T1, coronal T2, is that a post, and a diffusion and an ADC.
Exactly.
Okay, so this mass is centered in the skull base at the level of the clivus. It's T1 isointense, and it's T2 slightly hyperintense. It is slightly restricting diffusion.
Okay, that's I think the most important image in that data set. So you have a skull-based mass, very large, but still very homogeneously enhancement. And I put the diffusion there for some reason.
Okay, so it's hypercellular, I guess,
Yes.
since it's restricting diffusion.
Okay. So think of what kind of masses would reach large sizes without becoming heterogeneous or necrotic?
Yeah.
Not many will do that. There's one that is specifically famous for it.
Are we talking about like lymphoma?
Yes, we are talking about lymphoma. And to be honest, if you have any diffusion imaging, that's what I would pick right away. Not many pathologies can be really characterized by their diffusion characteristics or ADC values. Lymphomas are notoriously very, very low in ADC. The only thing that can look like lymphoma on ADC or diffusion weighted images, rhabdomyosarcomas, for example, can have also various hindered diffusion and very low ADC values around 0.6, 0.7. Maybe, chemical infiltration, chloroma can give you that, but that's it. Not many lesions will be this dark despite all this homogeneity. So large mass, homogeneous, dark ADC, you have to think about lymphoma and lymphoma alone. Again, another example, similar, very bright diffusion, and that's usually the clitoris. And again, if they give you numerical values, it's going to be around 0.6, 0.7. Squamous cell carcinomas usually don't get this low. They are around 0.9. All right, believe it or not, we are done, and I wish you the best luck in your next endeavor. I'm sure you're going to be good, and I know it's stressful, but hopefully, you'll also remember a few fun parts about this whole journey. Thank you so much, and I hope to see you soon somewhere else. Okay, now I'm ready for questions.
Yeah, so I have accumulated a list, and we have 6 total questions. So the first question will be about that labyrinthitis ossificans case. In these patients with labyrinthitis ossificans and cochlear implantations, would the ossification eventually lead to cochlear implant dysfunction? Like if you place it during that?
That's a good question. Apparently not. So once you place the cochlear implant, if you get ossification, I don't know if the hearing get any worse, but it still works. That's why they try to put it in before you get the ossification. So they know it's gonna get ossified at some point, and there is nothing really to prevent it. Even if you give steroid, that inflammatory reaction has already started, and as far as I know, there's nothing to reverse it. So it will end up with ossification. They know that. That's why they want to put that implant in before that happens.
So like the ossification, like once you place it in and then it ossifies, that won't disrupt the electrical conduction.
Correct. It can still transmit those electrical impulses and still innervate the cochlear nerve. The problem is technical. Once it ossifies, technically you cannot drill into it and place it. That's the problem.
Oh, I see. Okay. All right. Well, the second question was also about that labyrinthitis ossificans. You might actually have to go back to that slide, but they were wondering if you could point out the MRI findings on that case.
The first one or the second one, I wonder.
I think it was the first one. This happened right after that.
Just trying to see. Okay. So these again, I don't remember if those were Fiesta or KISS images, but nevertheless, normally in KISS or Fiesta images, you should have normal bright CSF signal in all the inner ear structures. As you can see in this one, the signal of the vestibule, for example, was much darker, dirtier than the CSF. Same thing with the basal turn of the cochlea here. And again, see here, the vestibule is much darker. Same here. And on the post-contrast images, you have abnormal enhancement in the vestibule, semicircular canals, and also in the cochlea, meaning that there is an active proliferation, inflammatory proliferation that is ongoing in the inner ear structures.
Okay, awesome. Thank you so much. Also, the third question is regarding the endolymphatic sac tumor in the large vestibular aqueduct. They were asking, how do you tell the difference between an endolymphatic sac tumor and a large vestibular aqueduct? So I think they were asking regarding that vestibular aqueduct, like how do you know that it's not an endolymphatic sac tumor?
So again, for endolymphatic sac tumor, it's kind of an expansile heterogeneous with multilobulated T1 hyperintense lesions. I'm just trying to, once I can try getting I'm trying to get it. With the dilated endolymphatic duct and sac, it's just as the name implies, it's a dilated sac. It's kind of this kind of lobular sac-like appearance. So it shouldn't look similar at all. Where is, okay, here it is. See how this thing is kind of heterogeneous. On MR, again, very heterogeneous. However, with the endolymphatic duct dilatation, it was very homogeneously and sac-like, basically. Here it is, I found it. See, it's really, it's very different. This is just a fluid-filled sac. Sometimes you can have this kind of a little bit of layering, like a fluid layering, but you don't have this heterogeneous changes. Of course, on CT, it's very, very different.
Okay, great. The fourth question is, how do you differentiate between chondrosarcoma and apical petrositis?
Okay, so chondrosarcoma, so apisitis, it's an infection, right? So you'll have enhancement, you can have adjacent leptomeningeal or dural enhancement, but you shouldn't have expansile lesion. Whatever happens should happen at these structures that are already there. Although the enhancement can look a little bit funny, you shouldn't have this expansile appearance. If you have expansile features, you have to think about a tumor, which is a chondrosarcoma. Furthermore, the age will be very different. Adults almost, I mean, I shouldn't say never, but petrosapisitis is really an entity that happens in small children, which is also the case for all the coalescent osteomastoiditis. They really tend to occur more in kids. However, chondrosarcoma is a malignancy of adulthood, so the patient presentation will be also very different.
Okay, that makes a lot of sense. The fifth question is the meningioma case. They were asking, you might have to go back to those images, but basically, is this a meningioma encasing any vessels? It was like the one that looked like it was touching the parotid.
I do not remember, so I'll have to go back to the images. You're absolutely right. I'm trying to find it. Okay, it was somewhere here.
Also, if you guys feel like I'm not representing your questions well, just speak up.
Okay, I think I found it. Was it this one? I guess so. So yes, it is, for example, encasing the ICA, and that would be actually, that's an excellent question, because that can be a useful finding too. Not many, well, for example, let's think of lymphoma. Lymphoma can really encase tumors, but it wouldn't typically narrow the vessels. However, meningiomas are somewhat notorious in doing that in the cavernous sinus region or in the extracranial soft tissue. If they surround the vessel, they tend to concentrically narrow that vessel. And actually, you can see that here too. Look at the ICA on this side and the ICA on the other side. So there is definitely concentric narrowing, and that's a very good point.
Oh, interesting. I didn't even realize that. Okay, so the sixth question, and we actually had another question come in, but would the meningioma case be considered atypical since it does not enhance?
So remember, the meningioma enhancement, this is something we always talk about on MR. On CT, the avid enhancement does not happen. It has, of course, enhancement, but not as, it will never be as bright as a glomus tumor. So don't expect to see the meningeal enhancement or enhancement of the meningioma as bright as you would see on MR. The CT enhancement, it does enhance, but it shouldn't be as strong as glomus tumor. For this case, I have to admit, I play with the windowing a little bit to make it look even darker than it was. But I'm just trying to kind of make the point of comparison. Like for comparison, it's never going to be, I think I had an image where we were side by side. Yeah, so even if you have kind of homogeneous enhancement, it's not going to be as arterial-like as glomus tumor. I think that might be a good way of comparing it. Usually glomus tumors will have this kind of density similar to the arterial enhancement. That wouldn't be the case with meningiomas.
Oh, interesting. Okay, thank you. And then the final question is, if you could just go back to the last case, if you could point
lymphoma
out
one.
The lymphoma. I think they wanted to see if you could point out the restricted diffusion, since the ADC looked similar to the cerebellum.
So whenever you have a skull base or soft tissue neck mass, you have to compare the diffusion characteristics to the adjacent soft tissues, not to the brain. That's why the restricted diffusion may not be the correct word, by the way. That's why probably hindered diffusion might be a better word. I'm not an expert on MR physics, so don't take my word for it. But compare it to the, for example, muscles of mastication, compare it to the surrounding soft tissues, not always to the brain. But from your practice, measuring ADC value, I think, is the most helpful thing. You know, just put an ROI on it and measure it. And if you have something around 0.5, 0.6, you know what that is.
Okay, well, thank you. So those were all the questions. I'm going to hand it back over to Almira.
All right, thank you again, Dr. Ozgen. So I think all of us will be getting all the points for a skull base and the temporal one, I guess.
I hope so. If I was even a little bit of help, I'm very, very glad about it. So, and again, I wish you all the best and all the luck. And hopefully I'll see you again in another meeting somewhere.
Absolutely. Thank you so much. Thank you for all the residents who joined and who volunteered to take cases. We hope everybody found this useful. And Grace just posted a feedback survey in the chat window. And please let us know what you think. And that's it. Good luck studying. Take